our first speaker today is Ravi Madan. He got his MD from the New Jersey Medical School in 2001 in Rutgers, and then he did a residency in internal medicine. He joined NCI in 2005 as a clinical fellow, and now he's in the genitourinary malignancies branch. He's clinical director, and he's going to talk to us today about treatment challenges in castrate-resistant prostate cancer, choosing and sequencing therapy. Ravi.
Okay, thanks for that kind introduction and reminding everyone that there's probably a better option to hang out outside than actually at this lecture today, but I thank you all for coming nonetheless. So what I'll be talking about today will be kind of an overview of how advanced or metastatic castration-resistant prostate cancer is treated. And in doing so, I will highlight the fact that actually there is no standard sequence, but it does give me an opportunity to provide rationale for how, as clinicians, we select treatments for our patients when there isn't real clear data on that. But it also gives me a chance to define what these therapies are, what their therapeutic targets are, and also what the side effects are, which is also a very important aspect, obviously, for clinician and patient perspective. So this is the landscape of prostate cancer over the last really 20 years. And so if you take a look down here, you basically have early stage disease where patients are newly diagnosed and potentially cured by surgery or radiation. And for the most part, that's about 60 to 80% of patients who are diagnosed. So I'm not going to talk about that today. I'll be talking about patients who have more advanced disease that's metastatic and castration resistant, which means it's growing despite hormone suppression of the testosterone levels. And I'll show you why that's important in a second. But for patients who have advanced disease, it's growing despite castrate levels of testosterone, so we call it castration resistant. And then metastatic obviously means it's spread to bones, lymph nodes, or organs. And you see that until basically 2010, we really only had one therapeutic in this space that had any evidence of improving overall survival, and that was a chemotherapy named docetaxel. That was followed by roughly 5 to 6 years of combination failures until a therapeutic cancer vaccine, Sipuleucel-T, came about, although this treatment was not without its controversies. This was followed by a second-line chemotherapy agent, Cabazitaxel, also in 2010. Shortly thereafter, 2 additional anti-androgen therapies, Abiraterone and Enzalutamide, were approved for post-chemotherapy metastatic prostate cancer in 2011 and 2012, respectively, before they were approved for patients who had not yet received chemotherapy in advanced prostate cancer. So they're kind of now approved throughout this whole space. And then also radium-223 is a radiopharmaceutical that was approved based on survival advantage. All these agents showed survival advantages. So it's interesting, you have an immunotherapy, a radiopharmaceutical, a chemotherapy, and hormonal agents. So very diverse options for therapies in this state. So this again highlights why testosterone is important in driving prostate cancer and again, the definition for castration resistance. So what this term means is that basically these patients have a suppressed level of testosterone, but their cancer is still growing. And this is either in the form of a rising PSA, which is a biomarker in the serum that can be used to detect prostate cancer, or on imaging. And this is a necessary definition because the androgen receptor is the driver of prostate cancer. And by having androgens or testosterone bind to the androgen receptor, it leads to a cascade of events that leads to intracellular signals that lead to cellular growth and proliferation. So in first-line therapy, when patients have early disease or metastatic disease, the first thing we do is lower their testosterone to castrate levels. And this can be done with a hormonal shot. It's rarely done with surgery these days, but that's also an option. But once that is no longer effective, that's when these other therapies come into play, and that's when we start talking about castration-resistant disease, which again is the focus of this lecture today, because the first-line therapy is chemical castration or surgical. So let me just also define another thing that may have already caused you some confusion, and that is I've already mentioned that 2 of these new therapies that have been shown to improve survival in prostate cancer are anti-androgen therapies. but I told you that my lecture is going to be focused on castration-resistant prostate cancer. So this actually is it sounds like a paradox, but it's actually, once you understand the resistance mechanisms that develop, you'll see that the androgen sequence of cascade of events that from androgen signaling is still the driver of disease, even in castration-resistant disease. So castration-resistant disease, again, means we've lowered the testosterone levels. But as the resistance mechanisms show, there's still sufficient androgens in the tumor microenvironment that can allow for the disease to be driven by this pathway. So one mechanism of resistance is AR amplification. So more receptors might be able to scavenge more or less levels of androgens in the tumor microenvironment. But this is more relevant when you take into effect that it's become clear over the last decade or so that the tumor cells themselves can actually produce androgens. So even though we're castrating with chemicals or drugs patients, that suppresses testosterone production from the testicles. It doesn't suppress testosterone production from other tissues, and now we found out that the cancer cells themselves can make their own androgens. There's also the potential for ligand-independent growth or androgen receptor splice variants. So what this means is you basically have a pathway that is active that leads to intracellular signaling that leads to cellular proliferation, but you actually don't need the ligand, in this case testosterone, to bind to that pathway. There's a mutation in the receptor that makes it constituently active. So that's another issue. And there also can be other intranuclear changes as well. So you'll see that by still coming in with some of the therapies I'm going to talk about, you can still target the androgen receptor in these patients and have a clinical benefit, even though they're castration resistant. So I just wanted to explain that apparent paradox. It used to be a term that we used to use called hormone refractory, but because clearly the hormone pathway is still driving this disease, that is really more of an outdated term as based on current knowledge. I'll just also highlight some data from 2015 that was somewhat surprising, I think, but in retrospect, I don't really think it should have been. And that is the fact that there are mutations in prostate cancer that are associated with the disease. I think for a while, some people thought there weren't a lot of mutations in prostate cancer, but I think we know better now. Not surprisingly, you probably can't see this in the back, but the primary mutations are in the androgen receptor, although the average patient, I think, had about 3 mutations. The real surprise from this actually came down here in the DNA damage repair pathway, and that's mutations like BRCA1. This is something that was surprising, that about 30% of patients with prostate cancer actually have mutations in the DNA repair mechanism that could potentially be therapeutically targeted, and I'll come to that at the end of this lecture. Not yet approved, but certainly a promising path forward. So the other part of this equation, before I get to some of our clinical dilemmas, is you need to understand kind of the house rules of dealing with prostate cancer, and it's based on a prostate cancer working group that has met 3 times over the years and really defined some rules that I think are very valid and important. The primary one, which as a clinician, but also as a patient, that's hardest to deal with, is that PSA is not a marker of treatment failure or disease progression on its own in metastatic disease. This basically, radiographic imaging should be your primary mechanism by which you judge either disease progression or the efficacy of a therapy. And obviously patient symptoms and their tolerability to therapy is also important. So when I see a patient, my primary thing is how are they feeling symptom-wise? Are they tolerating the drug? What does the imaging tell me? And then all the way at the bottom of the list is what the PSA is doing. Unfortunately, even in the community, I think it's still hard to really tear yourself away from the PSA. And it's also because the patients become very concerned. And it takes a lot of time to explain that, yes, your PSA was always important, you know, in your diagnosis. And when we determine that they had recurrent disease, it's often by PSA. But it's hard to detach patients from explain to them that it's not as important once you have metastatic disease, we can follow by imaging. Okay. So as I kind of alluded to in the opening, we have a lot of therapies for metastatic castration-resistant prostate cancer, or MCRPC, but there's no clear data that says this is what we should do and this is the order we should do it in. So in the absence of data, I'll provide my opinion and try to back it up a little bit, at least, with how you would choose the different treatment options for your patients. And I think, again, they're based on the rationale for this explanation I'll provide is really based on the treatments themselves, their side effects they have, the patient you're looking at, what are their comorbidities, and how do the side effects that are potentially possible going to affect that patient's lifestyle and other comorbidities, and how symptomatic is their disease, and how rapid the pace is of their disease. Hopefully that'll make a little more sense as we move through. So it's getting close to dinner time, so I do kind of use this analogy where our treatments are somewhat like a menu. So if you have a patient, and hopefully no one's getting too hungry, I think they just closed the coffee shop outside, so you're gonna have to tough it out here. But these are kind of the options you have for your patients and how I would break it down. I think Sipuleucel-T we'll talk about. It's an appetizer. Appetizers aren't for everybody, but some people like them, and I think in this case, treatment's not for everybody, but I think in selected patients, it could be a very good therapeutic option. Your first course is probably one of the anti-androgen therapies. They have less toxicity, and if the disease is not moving too rapidly, I think and the patients aren't too symptomatic, I think it's a good option. Second course consists of a little more toxic therapies of docetaxel and radium-223, and the third course is a second-line chemo agent, and then some of the additional options we haven't chosen yet earlier in the menu. So we'll start off with the appetizer, as I've labeled it here, which is Sipuleucel-T. And I think the ideal patients for this are early metastatic castration-resistant prostate cancer, patients who have minimal symptoms and low volume and slow pace of their disease. There's different retrospective studies that show that in prostate cancer, immunotherapy may work best in these type of patients, and I think there's some specific data with Sipuleucel-T. So what is Sipuleucel-T? So you've heard a lot in this lecture series about immunotherapy. Probably haven't heard about therapeutic cancer vaccines because there's really only a couple approved, and the other one is a lytic vaccine. So this is kind of unique in the oncology space. It's actually patient specific. So it's derived from a patient's own peripheral blood mononuclear cells, which are collected via apheresis or leukapheresis. They're shipped to a central processing facility where they're exposed to the target antigen, which is prostatic acid phosphatase, along with a cytokine called GM-CSF, which basically enhances immune activation. Those activated immune cells are then shipped back and reinfused in the patient. So basically, you put the patient's immune cells through boot camp, giving it a target, and hope it can really seek out and destroy that target in the patient. A full course of therapy consists of 3 infusions once every 2 weeks. And here is the trial that led to its approval. It was basically a 2-to-1 randomization between the vaccine and a placebo. And overall survival was the endpoint based on some earlier studies. So this phase 3 trial demonstrated a clinically meaningful and statistically significant improvement of 4 months in survival benefit with really limited toxicity. So this actually, as I pointed out earlier, was FDA approved in 2010, but I mentioned that there's controversy with this, and this is where it stemmed from. So I think now a lot more people are more familiar with immunotherapy, but in 2010 it was very much less common than it is now. So when no one saw that, and you can kind of see a little bit with these overlapping survival curves for the first 6 months, when people didn't see PSAs go down and they didn't see disease melt away on the scans, even to this day, there are people who don't believe this therapy works for that reason. I think the survival data speaks for itself. There's actually 2 phase 3 trials, one that was done earlier where this was not the primary endpoint, which demonstrated a very similar survival advantage. And I think, I think this data is legitimate, and it does make sense for what we know now about immunotherapy. It also highlights what I mentioned earlier. If you have slow-moving disease, this is probably a reasonable treatment, as opposed to if you have 6 months to live, it might not impact your patient. So that's why I think this could be used up front. I also mentioned that lower tumor burden might be a reasonable choice of population to use this in. So I'm speaking out of both sides of my mouth here. I told you PSA is not important, and it's not a perfect indicator in tumor burden because it's not proportional to a patient's tumor burden. One man's PSA of 5 is another man's 50, is another man's 500 in terms of relative tumor burden. But what this subgroup analysis demonstrated was that patients who had the lower PSAs, which may likely correspond to a lower tumor burden, had a greater improvement in survival than if you had higher PSA levels. So it's not like you were going to do better anyway. If you had a low PSA, less than 22, your median survival was much better with Sipuleucl-T than if you gave it to someone whose PSA was over 100. The marginal improvement was less. So I think people are always like, well, Sipuleucl-T, if you don't know it's going to work, how do I pick my patients and who to use it in? Again, slower pace of disease, but also perhaps to some degree tumor burden or lower PSA may be a reasonable thing. So that would be the patient I would recommend. These are the toxicities that we're seeing with Sipuleucl-T. So I'll go over the toxicities again with each of these therapies, not because you can memorize them, because as you'll see, these slides get more and more dense. But just again, these are things you want to factor in so you don't, so you pick the right treatment for your patient. So these are all pretty mild infusion-related side effects. You know, I should probably take the stroke thing off. This really hasn't been validated in post-market testing, so I don't think there is a stroke risk with this treatment. But it's actually pretty well tolerated, and some patients have kind of reactions shortly after the infusion, which actually could be very similar to an immune effect. So I don't necessarily think it's a bad thing. So that's Sipuleucl-T. And I guess for those of you here, if you have any questions, feel free to stop me at any time, and we'll try to answer them. So as we move on to the next course, we're kind of on to the first course. So whereas not everybody gets an appetizer, and I've tried to define who the right people are, I do think the first course is hopefully for most of the patients, especially if they have minimal to moderate symptoms. And the first drug I'll talk about in this situation, the other thing I'll mention is that Sipuleucl-T doesn't really improve pain symptoms either. So that's another reason why I would choose slow-growing patients without a lot of symptoms. But enzalutamide is a very well-tolerated therapy, which has minimal side effects, and probably also works well. Even if you have moderate pain, it's been shown to improve pain symptoms. Abiraterone is also very similar and well tolerated, although the difference between these two therapies on a kind of a treatment administration level is that abiraterone requires prednisone. And so prednisone comes with its own side effects, and I'll explain why we do that shortly. So here's enzalutamide. So I mentioned earlier that targeting the AR pathway in androgen receptor in castration-resistant prostate cancer is still therapeutically viable. There was about a decade where I think we kind of forgot about this, and then enzalutamide was developed, and it kind of reminded us how important the androgen receptor pathway is. So basically, what this agent does is it binds to the androgen receptor and with a very high affinity and prevents androgens from binding to that receptor. It also has downstream effects on the androgen receptor, including limiting nuclear translocation of the receptor into the nucleus, which again leads to the driving or proliferation of the cancer cells. So you see these are all comparisons to bicalutamide. Bicalutamide is an older androgen receptor antagonist, which, as you can see, wasn't as effective as enzalutamide. And bicalutamide actually, in metastatic castration-resistant prostate cancer, never demonstrated a survival advantage. So basically what happened, about 15 to 20 years after bicalutamide was developed, they built a better mousetrap. And this turned out to be like $1 billion mousetrap, and they called it enzalutamide. And it really did have results that we didn't see with other androgen receptor antagonists. This is the phase 3 study that was done where they gave people enzalutamide versus placebo, again, a 2-to-1 randomization in patients who had already had chemotherapy. And the reason why it was done in the late stage of disease is because that's where you're going to get a quicker readout. And you'll see that in this 1,200 patient study, there was a very robust improvement in survival from 18.5 months to 13.5 months. Time to progression also improved, and this led to FDA approval of the agent, again, in patients who had already had chemotherapy. So this was followed up by another trial that was actually, they both were started at the same time, 1,700 patient trial done in patients who were chemotherapy naive. And you see that basically you had almost a better effect because these are earlier in the disease, so that's why they're going to live longer. And you'll see that the 1-year progression-free survival was 65% versus 14% in placebo. So very profound effect. The overall survival actually is statistically significant, but you might think real quick, well, a 2-month improvement in overall survival, that's not that big a deal. Why are we using this therapy if it's going to have side effects and cost a lot of money? By the time this study was done and these patients had lived 2.5 years, many of them probably lived to get enzalutamide at some point or another drug like it. So it's for as you learn more about clinical trials, it's something called a crossover effect, whether it's part of the design of a therapy trial or just a functional aspect of having a drug approved and having other drugs approved in the space. You probably get a survival estimate that's underestimating the actual treatment effect. And I think that's what you're seeing here. So if somebody were to say, well, enzalutamide only improves survival by 2 months, I would say that that's probably not accurate. You're probably getting kind of a crossover effect here. So basically now enzalutamide is approved for all advanced metastatic castration-resistant prostate cancer based on these 2 studies. So what about toxicities? It is pretty well tolerated. There can be fatigue, though, and I've seen fatigue profound in some patients who, even though the drug works, say, I can't take this anymore. So we don't want to underestimate the fatigue, which I think is the greatest clinical obstacle. But otherwise, it's a very well-tolerated therapy with really minimal side effects. It is important to know, though, that there are some, and this has kind of been a class effect noted with some other agents similarly, there is an increased risk of seizure that was seen with these type of therapies. And so in the phase 3 study that was done, they've actually excluded patients with strokes. So if I have a patient who comes to me and I said, I don't have data as to whether to give you enzalutamide or abiraterone, I'd probably give them abiraterone if they had a history of a stroke based on the lack of safety data in that population. So that's one aspect of how you could stratify your treatment options. The other way to look at this is that it's important to note and sit down with an educated pharmacist and go over the patient's med list so that if they have a drug that lowers their seizure threshold, like a stroke would, or you may not want to give them enzalutamide if they can't substitute that medication. So just be very cautious with history of stroke with enzalutamide. So the other option that's also equally impressive in this first course is abiraterone, which, as I mentioned, the drawback with that is that it requires prednisone. So I mentioned that the resistance mechanisms for prostate cancer, that's when it's castration resistant, one is overexpression of the androgen receptor. The other one I mentioned, which sounds pretty crazy, but is the capability of the cancer cells to produce their own androgens. So if you see here the CYP17 pathway here, that is one mechanism by which cancer cells can process cholesterol and then basically transform it into androgens to fuel the cancer's growth, almost in an autocrine or paracrine fashion. Now, abiraterone was developed to block these enzymes and therefore likely significantly reduce these secondary mechanisms of androgen production. And so this may happen in the adrenal glands, but it's also likely to happen within the prostate cancer tissue as well. And that's probably where it has its greatest therapeutic impact. So much like this was co-developed in the same time frame as enzalutamide. So the trial designs and strategies are very much the same. They took patients who had chemotherapy and gave them either abiraterone with prednisone or prednisone alone. So the prednisone is really a control agent. The reason why they give prednisone is because, I'll go back to this slide, you can get, with blocking these enzymes, you actually can get changes in your cortisol levels and your cortisone levels. And that can lead to side effects like hypertension and edema in the legs, which are really potentially obstacles in using this therapy. But by giving prednisone, you can actually minimize this toxicity. So prednisone here is actually used to minimize the toxicity of abiraterone. And then just so you have that background. And again, this was a survival endpoint study, as were really all the studies I'll be talking about today. So I think that this, again, was a clinically meaningful readout of a survival advantage of about 15 months to about 11 months. And I want you to remember this because this is abiraterone, and people at the time may have said, well, 3 months survival is an incremental gain and it's not that big a deal. I'll come back at the end of the lecture and show why I think time has proven that statement inaccurate. But this led to FDA approval for patients who had already had chemotherapy and castration-resistant prostate cancer. Again, you see there's a progression-free survival advantage. PSA response rates, of course, were higher relative to placebo, and the ultimate readout on survival, again, was about 33 months. I'm sorry. So just like with enzalutamide, I'll take a step back here. What I'm showing you here now is the data from the second study, which was in the chemotherapy naive patients. And so in this study, which was designed very much the same as the post-chemo study, you see that there is, again, a 33-month survival advantage and it's an improvement over placebo. And again, the FDA basically has approved abiraterone now for all patients with metastatic castration-resistant prostate cancer. Now, as we get to the toxicity here, you see that, yeah, there's a little more toxicity with this than enzalutamide. And that's why, personally, I'd favor enzalutamide given the two options, without any other cost constraints or anything, because you do get things like hypertension and edema from this agent. Fatigue's still an issue. You can get some hyperglycemia issues because of the prednisone. But don't forget, being on steroids has its own side effects, and they are probably baked in here a little bit. But we know that steroids can weaken the bones. Again, hyperglycemia comes with steroids. So it just adds a certain level of kind of added toxicity to this regimen, even though it's there to minimize the direct toxicity of the abiraterone. So again, I'm showing you the toxicity screen so you can understand that this is what I think about when I have these patients in my clinic. I'm like, all right, well, which one of these, is kind of the best way to go? So can't you just use both, maybe one and then use the other? And there is now actually, for a few years now, evidence of cross-resistance that's actually telling us that you actually are likely to only benefit from one of these therapies fully. So it seems like the resistance mechanisms that are developing when you have either of these agents likely limit the benefit of the second agent. And so this was highlighted by work done at Johns Hopkins initially by Dr. Antonarakis and his group up there, where they looked at a concept of androgen receptor splice variants. So as I mentioned this earlier, by alternatively splicing the mRNA of the transcript for the androgen receptor, you can actually get an androgen receptor without a ligand binding domain. So what that means is you basically have a switch, on-off switch without the on-off button, but the wires are connected on the inside and they're always on, regardless of whether you turn it on or off. So in other words, you have a constituently active androgen signaling pathway within a prostate cancer cell telling it to grow even if there's no androgens around. And what they were able to see was that in patients previously treated with abiraterone or enzalutamide, you can tell by these arrows here, that they were more likely to have this splice variant. They called it ARV7, androgen receptor variant 7. And then if you had those splice variants, as you can tell by the patients in gold, that they were more likely, well, they were less likely to have a PSA decline. So what this is telling us is that by using these treatments, you're developing kind of a secondary resistance, in this case, ARV7, that really limits the potential benefit of the second therapy. So I think that we know now there's probably multiple other variants beyond ARV7. There's an important proof of concept and highlights the fact that you're not really going to get your bang for your buck out of both these agents. You're probably only going to use one, and so therefore, you might want to, again, use that toxicity profile to pick it. This is even, I think there are other countries that even tell providers you can only use one agent from a cost standpoint because we know the other one's not likely to work. So just not to talk about policy, but just so you have an understanding about how that data plays out in the real world. Now, when we get into the second course on this menu, I'm generally thinking of patients who have more moderate symptoms. So they've either progressed, they had their first course, and it didn't work, and then you're moving on, or if they come into your office from the very beginning, they may not have had one of these initial treatments, but they may have more symptoms or a large tumor burden or rapid pace of disease. And in that setting, the chemotherapy, I think, is still a good option in prostate cancer. And I think it is probably the best option for patients with substantial symptoms, again, a high level of symptoms and fast-paced disease. So docetaxel, when people say don't cut down the rainforest, this is one example of why not, because taxanes were discovered in the Pacific Northwest from the yew tree, and docetaxel is a kind of a synthetic kind of derivative from that initial discovery, and it's used in many cancers, including prostate cancer. And its mechanism of action is thought to inhibit microtubules from forming and disassembling in kind of intracellular pathways. So it was thought that if this was interfered with, then you can't have mitosis and cancer growth. But actually, there's newer data that suggests that taxanes may actually inhibit the androgen receptor's mechanism by which it can travel from the cell membrane to the nucleus. So think of those microtubules in that context as like a railroad track, and docetaxel is kind of preventing that from forming. It's interesting because you reminded a little bit that in prostate cancer, it really comes down to the androgen receptor always. And it does explain why the only chemotherapies that work in prostate cancer are taxanes. There's two, and it's strange that there's two approved, but based on data. So just some interesting science background there. So this was a study done actually around the early part of the 2000s, where they took two different schedules of docetaxel and compared it to mitoxantrone and prednisone. So mitoxantrone, it's not on my slide I showed earlier, but it is FDA approved for palliation. It's very uncommonly used now, but it was approved in the 90s. It didn't improve survival, but it improved symptoms for patients with advanced prostate cancer. And so that was the relevant comparison at the time. As a side note, prednisone may limit some of the toxicities of docetaxel, but that wasn't why it was included in this regimen. It was included in this regimen basically because mitoxantrone is used with prednisone. So it's really an artifact of clinical trials design to some degree, although a lot of people do think it minimizes toxicity and maybe has a therapeutic effect in addition. And interestingly, prednisone is included with mitoxantrone because when they did those phase 3 trials, they did mitoxantrone and prednisone versus prednisone alone. And they said, well, let's just throw the prednisone in with the mitoxantrone. So it's really interesting that prednisone is in all these arms because of really, again, an artifact of clinical trial design. So it's always good to understand how these trials came about so you understand as a clinician, if they're having side effects like hyperglycemia from the prednisone, do I feel comfortable removing it? I actually would because of kind of the rationale that I just explained to you. So this is the data from TAX 327, which demonstrated that chemotherapy improves survival. So it basically shows the green line here of every 3 weeks of docetaxel was 19 months versus 16 and a half with mitoxantrone and prednisone. And basically, based on this was a statistically significant improvement in survival, and really the first time anything showed an improvement in survival in prostate cancer, and so it led to FDA approval. And it was preferred over the weekly, as you can see as well. So two things to look at this. Remember, this was done a decade before the Abiraterone and Enzalutamide trials. That's why those are 30 months, because those patients had the opportunity to get docetaxel and the Abiraterone and the Enzalutamide. So that shows actually the 30 months there. It shows the progress over the decade since this was 2004. But the other thing that I think you should look at, and patients will bring this up from time to time with me, am I really going to get chemotherapy for only living 2.5 months longer? All right. So anybody want to guess why I would say that's not an accurate interpretation of this data? Okay, well, we talked about this earlier, but in this study, there was a crossover allowed. So if patients got mitoxantrone, they were allowed to cross over and get docetaxel at the time of progression. And the studies with mitoxantrone at this time frame suggested that the survival in that group would be about 10 months. So they actually did much better than they were expected. And again, that's probably because of a crossover effect where patients who progressed on mitoxantrone were able to get a therapeutic benefit from docetaxel. So I've actually spoken at support groups and things, and oftentimes patients will tell me, I'm not going to get chemotherapy if it only makes me live 2.5 months longer. And it takes some explaining, but they usually understand after we talk about it that this is, again, not really a 2.5 month improvement. You're actually seeing the mitoxantrone group probably benefiting because a lot of them went on to get the chemotherapy. So this is the other thing I just mentioned earlier, the crossover effect. So you're actually seeing an underestimate of the survival advantage here of docetaxel in this study. Now, it's important as a clinician to know about this because you do have people who see this data and say, it's not worth it for me to get chemo for 2.5 months. But I actually think chemotherapy is a very important treatment in this disease state. So any questions about that? Okay. So, but it is a chemotherapy. And so I told you these side effect screens would get a little bit denser. And I don't expect you to, again, read everything even, although I know you guys, some of you in the room have a printout. But the biggest side effects you really have is neutropenia, which can lead to neutropenic infections and death. And that's really the biggest thing you have to educate your patients about, along with the neuropathy. So you can get peripheral neuropathy, which is usually starts off as numbness in the fingers and the toes. And if left unchecked, you can really, it can be permanent. So if it develops in patients and you stop the chemotherapy at early onset, it's likely to reverse itself within a year. But if you just keep treating them, there's a chance that they might not be able to hold their cup of coffee or walk because they just lose feeling in their fingers and toes. So those are really the side effects you got to be most aware of and educate the patients about. Other things are on this list as well, very typical of chemotherapy. This doesn't have a lot of nausea, which is good. It's very easily contained with a simple antiemetic regimen at infusion, so that's good. So it doesn't have that typical side effect. But so again, I kind of mentioned who should get this disease. So that's patients who either the other treatments, the abiraterone and enzalutamide, no longer are effective, or they have a lot of symptoms. And so if they have a lot of symptoms, kind of you look at a risk reward. The reward is that, yes, this has a lot of side effects. These patients come to you with a lot of symptoms, and you're hoping you can minimize some of those symptoms by giving them this chemotherapy. So this side effect page, again, reminds me that if I have an asymptomatic patient with kind of marginally slow-growing tumor, I'm not inclined to give them chemotherapy right away unless they've had abiraterone or enzalutamide. So that, again, that's kind of why this slide's up here. So what else can we do for our patients with moderate to substantial symptoms? And I think radium-223 is a good option, and again, highlights the diversity of therapeutic options in prostate cancer. So this is for patients who have symptomatic bone disease, and the study was done without visceral disease, although I think we can debate whether that needs to be carried out in clinical practice or not if they're getting it with other agents. But we still don't know the perfect population for this agent. And to be honest, clinicians don't know precisely how to use this because older radiopharmaceuticals like samarium and strontium in prostate cancer were FDA approved for palliation but didn't show a survival advantage. And so they were usually reserved for late stage patients who'd already probably had chemotherapy but had a lot of bone pain. And I think that's kind of where a lot of clinicians use radium-223, but maybe it's not the right spot. We probably need some more data on that. So what is radiopharmaceutical or radium-223? So it's basically a chelated agent that basically is radioactive and fires off alpha particles. This is an improvement over samarium and strontium, which fired off beta particles. Now, I'm not really a physicist by any stretch, but what you need to know is that alpha particles are bigger and heavier, so they travel a shorter distance, which means that you're going to have less bone marrow toxicity, where you have the radiation kind of destroying progenitor hematologic cells like red blood cells or white blood cells or platelets. For the older radiopharmaceuticals, the beta particle agents that shot off in much greater distances, you saw a lot more of heme toxicity, and that was really a treatment limiting aspect to that agent. But with this, it's much less reduced. And so this probably does open it up for a better population of patients. And obviously, it binds to an area of high bone turnover in the bones, which is likely to be present if there's cancer cells there, and then hopefully kills the cancer cells. So this was a study, again, done in that 2010 to 2011 area where just chemotherapy was approved, and it was radium-223 versus placebo, and this was the results of the study. A little bit like Sipuleucel-T, which I mentioned earlier, there was no short-term progression, and we don't expect PSAs to go down with this agent. So I think that also is another reason why I think clinicians have a harder time using this agent. And when you package it with Sipuleucel-T, you realize, again, that as clinicians, I guess we're just not comfortable using agents that don't make PSA go down. I think that's still an obstacle, even though that's really not probably shouldn't be our guiding light. But nonetheless, you see here that there's a clinical, I think, statistically significant and clinically meaningful improvement in survival. It's also important to note that this study was done with allowed radium to be given with older androgen receptor antagonists, like the bicalutamide. Now, enzalutamide and abiraterone were not approved at that time, but it was given in combination with those agents. And then I don't have it in this talk, but there's also now post-marketing study where abiraterone and enzalutamide can be given safely with radium. And so I think that presents an opportunity to use this with those agents in patients maybe who have more soft tissue disease, because as a reminder, the radiopharmaceutical that's binding to areas of high bone turnover is probably not going to impact patients who have concomitant disease in the lymph nodes or in organs. But maybe if you can use it with abiraterone or enzalutamide, where you can see lymph nodes shrink or visceral lesions shrink, you can get the benefit of both. And we don't have clinical data that says it's definitively better, but there is safety data that was published, I think, a little over a year ago. So this was some subgroups. The other thing that's different about this study, and again, you really can't compare the survival across different studies. This was a kind of a heterogeneous population of patients who already had chemo and those who did not. And what we see is that the overall survival benefit is present regardless of whether they had chemotherapy. So even if patients got this a little earlier and lived a little longer, they were more likely to benefit. It wasn't as clear that patients were going to have a palliative benefit post-chemotherapy, which I think is a little bit perhaps because it was a smaller number of patients. But I think also the fact that it's probably a sicker population. But I do think that in the earlier population, you could see that there was a benefit in terms of palliation as well as survival. So I think it's reasonable to use both radium-223 regardless of whether they've had chemotherapy. And the side effects here, while it doesn't have as profound side effects, it does impact the bone marrow, and we have to be aware. But these grade 3 and 4, which are kind of your moderate to severe side effects for low blood counts, is actually much less than what we saw with older radiopharmaceuticals, which were beta emitters. So I do think radium-223 has a role, probably in more symptomatic patients. And that's, again, that second course. So what do you do if you've already had your second course, your docetaxel and or the radium, and you're not having benefit? Then you come to our third course here, and really you're kind of left with a few options. One is the Cabazitaxel, which is another second-line chemotherapy in prostate cancer. And again, it was kind of developed in that early 2010, 2011 timeframe. So what is Cabazitaxel? I'm also not an organic chemist, but it differs from docetaxel really just by a couple hydroxyl groups. So it's not that much different. But it did have a clinical impact, and it also has, I guess, some less affinity for a pump that actually could be a mechanism of resistance that develops, this glycoprotein pump that can develop in patients when they've had docetaxel and perhaps limit its efficacy. But other than that, it's very similar. And so what they did in this trial was they took patients who'd already had chemotherapy and had progressive disease, and again, randomized them to either that mitoxantrone and prednisone regimen or Cabazitaxel. And as we said, prednisone is here because it's part of this regimen. And this was surprising when it came out. There's kind of a modest progression advantage of 2.8 versus 1.4 months, but the survival advantage was about 2 or 3 months. And again, clinically or statistically significant. And actually, this was approved before abiraterone or enzalutamide, so we didn't really have a lot of good options at that time. And you see that it was surprising to a lot of people, myself included, that patients who had docetaxel would then benefit from another taxane. So I think perhaps it goes back to that mechanism of action that we talked about that may be unique to taxanes about impacting the AR translocation. So so this led to FDA approval for patients who'd already had docetaxel. What about patients who hadn't had docetaxel? So that study was done actually and completed last year. And what they found was that this was not superior to docetaxel for patients who were chemotherapy naive. So the frontline therapeutic option really still remains docetaxel. It's probably a little bit cheaper and probably a little bit better tolerated, or at least I think clinicians are more comfortable with it. But there's really not data to use Cabazitaxel up front. But I think this was a legitimate question to ask. They also saw that dosing wasn't different. So in this study, they actually looked at 25 milligrams, but there were a lot of dose reductions for myelosuppression. So they figured out that 20 milligrams was just as good. So for toxicity, this was an international trial where growth factor was not regularly used. And whether or not it was because these patients were heavily pretreated with chemotherapy before or not, I guess I should have highlighted, although all the heme side effects are highlighted here, the fact that 82% of patients had substantial drops in their white blood counts put them at risk for infection. And I think there was like a 5% or so infection-related death in this study, which was very concerning, and I think limited ultimately the use of cabazitaxel to some degree, especially when the other agents came along. So I do think it has a role. Like I said, if you've had all the other options on the menu, I do think it has a role, but I would strongly consider using a growth factor. So remember, I've already shown you this data. Enzalutamide, abiraterone, and radium-223 all have survival advantage data in patients who've had docetaxel. So if you get to this third course and you haven't sampled these things from the menu yet, remember, third course is kind of docetaxel refractory, then you can still use those treatments in this setting, okay? The one other thing I'll say is that, and one thing that, again, I think we need more data on, but I think you can do this safely. I mentioned here that you can probably only use abiraterone or enzalutamide up front in terms of using one or the other, but probably not get therapeutic benefit out of both. So what I'll often do is use enzalutamide, because I think the side effect profile is a little bit better, and if there's no seizure or stroke risk, or I guess seizure risk is what it is with enzalutamide, not stroke, my apologies. But, and then if they progress on that and they have moderate symptoms, I'm more inclined to go towards docetaxel, because I do think it has benefit, or radium. But if they get to a point where they've had docetaxel and they've had enzalutamide, when I come here, I'm inclined actually to combine the radium-223 with the abiraterone, because as I mentioned, there's some safety data, and then potentially they can maybe get benefit from both therapies. So, and it also maybe is a way to circumvent some of that overlapping mechanism of resistance data I showed. But I think we need clearer data to really recommend that, but it's just something that I think is not uncommon, or it's commonly done, or it's done, I think. And part of the reason why we can do that is because we do have clear safety data from that combination. The other thing I didn't mention, but I probably should have, was you may be wondering, well, there's AR-resistant overlapping mechanisms, whether you have abiraterone and enzalutamide, how does that impact your responses on docetaxel? It doesn't seem to. So it doesn't appear that the resistance mechanisms in all patients that develop on abiraterone or enzalutamide limit the efficacy of the docetaxel. So that's why it's kind of a logical next step. All right. So I think the ultimate goal, as we as clinicians see these patients in clinic, is to really do develop a strategy with the patient and kind of maximize their ability to sample from the different items on the menu and maximize their quality of life. And by doing that, I mean kind of minimize the toxicity, but also addressing their symptoms when appropriate. So even though it's kind of a little hokey, this whole menu thing, I do think it kind of spells out how a lot of clinicians go through this in their mind. And again, there's no clear flow chart, but I think that when you start weighing the benefits, resistance mechanisms, and toxicity, it does become a little bit clear what the options are for the patients. So we can kind of look a little bit to the future by looking at the specials on our menu here today, which has to do with PARP inhibition. So this has actually received breakthrough status from the FDA, and there's several large phase 3 trials going on to prove its efficacy. But I mentioned this earlier, that roughly a third of patients have mutations in their tumor of DNA damage repair pathways. And as you know, PARP inhibition actually can induce synthetic lethality in cancer cells that have deficient mechanisms of DNA damage repair. So a lot of the excitement for this comes from a very small study. They took 15 patients, they treated them with a PARP inhibitor, and 14 of the 16 patients who responded, and all 14 of the patients with, which again works out to roughly a third, but all 14 of the patients with the DNA damage repair pathway mutations responded to this therapy. And so based on that, there's a lot of excitement. It's expected that this probably will get breakthrough or official approval status when we get more data, but it does have breakthrough status now. And again, like I said, it's because roughly a third of the patients have mutations in these DNA damage repair pathways. So before I don't want to confuse things a little bit. So I've been talking the whole time about metastatic castration-resistant prostate cancer, and I want to highlight this newer data actually with therapeutics has actually come in a whole different disease space. It's going to be different by one word, but it's a significant difference. What I'm going to be talking about now is metastatic castration-sensitive prostate cancer. So let me fast forward a slide here. And I'm going to be talking about data from Charted or ECOG 3805. So the disease space I'm talking about isn't this space that's castration resistant and metastatic. It's actually a space that's here where patients have castration sensitive disease, but they're actually metastatic. Okay, so this is not a license to use chemotherapy earlier necessarily, but it's actually a population of patients who either walk into their doctor's office and didn't know they had prostate cancer and find out they do, and because it's metastatic, they're not eligible for curative surgery or radiation. So it's metastatic. They haven't had hormone suppression yet, so it's likely castration sensitive, and that's the population I'm talking about. The other population, the other portion of this population is a group of patients who may have had radiation or surgery. They were in follow-up, and for some reason or another, they go from perhaps thinking they were cured to, because of the biology of the disease, or maybe they weren't seen for a couple of years, they show up with metastatic disease. So fundamentally, these are patients who don't have testosterone suppressed levels of their androgens, but do have metastatic disease. So that distinction makes sense? This is as opposed to the bulk of patients who are metastatic who become metastatic when their testosterone is already suppressed because of that therapy being used kind of earlier on. So does that make sense? And everybody clear on that? So these are basically relatively newly diagnosed metastatic disease where the androgen suppression is likely to have a therapeutic impact. And so for years, that was our standard. We just gave these patients hormone suppression. And a study was done actually, I think around 2005, 2007, where they said, let's use chemotherapy because we know it works in advanced disease. Let's add it earlier on to this subset of patients, which is probably about 10 to 20% of patients. So it's not the bulk of the patients. And so survival data came out on this back in 2014, published in 2015, that showed actually a pretty pronounced survival advantage. Patients who got chemotherapy versus ADT alone lived about 13 and a half months longer. And for this reason, for these patients now, we give them 6 cycles of docetaxel, which is what they did in this trial. So this doesn't mean that this doesn't override what I told you earlier about using abiraterone and enzalutamide up front. It's a different population. I can't emphasize that enough because if I don't, it kind of really misses the point here a little bit. So now it's good because we have a way to substantially improve the survival times of patients with this disease or this stage of disease. And again, I kind of gone over the population, but again, it's not an earlier indication to jump docetaxel here. It's more like in this state here. Okay. But there was data from this summer that actually showed that abiraterone, so remember the abiraterone is the anti-androgen agent that's approved for metastatic castration-resistant survival. When that got approved in 2013 or so, they launched this study where they basically asked the same question, which was, can we improve on the androgen suppression in the same population? We didn't know the chemo results at this time, so it was a good question to ask. It's probably still a good question to ask. And the end results of this study was that if you gave abiraterone in this population, this was just presented this year at ASCO, you had a 38% risk reduction in death and a substantial improvement in survival. So now for patients who have metastatic castration-sensitive prostate cancer, we have data that says that docetaxel and abiraterone both improve survival. So we're back to that other problem that we have with metastatic castration-resistant disease, which is, which do we use? There's no data that really shows this. At an international meeting in Europe just this past September, the group from London who has run a series of trials called Stampede actually had contemporarily, at the same time, accrued patients who they gave abiraterone to and docetaxel to, and the preliminary data suggested that the survivals were roughly equivalent. So it looks like they both work, and just like with metastatic castration-resistant disease, We don't clearly know which one to use. So I think the one thing that I would say, my bias is again, talk to the patient, figure out what their strategy is. We talked about the toxicity from abiraterone and enzalutamide, from abiraterone. If you get abiraterone, you're going to be on this for a few years until you progress. That comes with the prednisone. But if you can get away with the chemotherapy for 6 infusions, you may not need another therapy for a little while thereafter beyond the hormone suppression. So it's kind of, some people are like, well, this is great. Why would I give chemo when I can give a pill? But the other part of the equation is if you can get away with 6 infusions of a well-tolerated chemotherapy and avoid some of these side effects and keep the tumor in check, is that a better way to go? We don't have the answer. The other part of this equation is, does prolonged exposure to abiraterone or abiraterone breed a more resistant tumor down the road? And I think that's an open question that people are asking. So in terms of our choice of therapies. So maybe have more data from that as smart people ask that question, smarter people than me. So we'll see what happens next year. But there are a lot of treatments for prostate cancer. I think it's very remarkable to have been working in this field and see all this evolve. This menu only had docetaxel on it in 2010. And it's great for patients that we have all these other options. There are studies going on looking at combining a lot of them, like abiraterone and enzalutamide. Some preliminary data doesn't show that using them both is really better than using one, but I think we need more data from those studies. And there's studies looking at the sequencing question. I do expect in the near future that PARP inhibition will be added to this list as well. And hopefully we can add some more immunotherapies to this mix. You'll notice we're a little deficient on that standpoint, although I do think Sipuleucl-T is a viable option. So I want to thank you for your attention, and if there are any questions, maybe we have a couple minutes. Okay.
Anyone tried the immune checkpoint inhibitors in prostate cancer?
Correct. So I didn't talk about the negative trials that we've had. Ipilimumab, which is an anti-CTLA-4 checkpoint inhibitor, actually had trials in both chemotherapy naive and post-chemotherapy prostate cancer, and it did not have a survival advantage. There was a therapeutic vaccine called Prosvac, which is a little different than Sipuleucl-T, that was developed here at the NCI. And just earlier in September, actually, they had a phase 3 study that also did not improve survival. I think, as someone who does immunotherapy in prostate cancer, I think there's a path forward here, but I think that path is in combinations. To this point, the anti-PD-L1 or anti-PD-1 has not been too remarkable on its own. There is some data from Oregon where they've used it in combination with enzalutamide, and they're seeing a response rate of about 20%. I think the story is yet to be fully written on immunotherapy in prostate cancer. I'm biased because that's what a lot of my research is here, but I do think that story will have a happy ending. Yes?
You mentioned that you will not use the PSA as a measurement, instead use the imaging and the symptoms. And do you have the same approach for general population or
So I think for all patients that have radiographically evaluable disease, that should be our primary assessment. Really, I guess the primary assessment really should always be how the patient's feeling, which is broken down into how they're tolerating the therapy and what symptoms they have. And then imaging is number 2 or 3 on that list, but probably a very distant 4th is PSA. So I will have patients who are on enzalutamide, and if their PSA starts to go up, they get nervous, but I tell them, listen, your scans are stable and you can still benefit from this therapy and you should stay on it. And I've had patients actually on enzalutamide have had rising PSAs for 18 months. So when I look at it that way, and they're tolerating it well, and radiographically their disease is stable. And from my perspective, if you take a patient off too quickly, you might be shortchanging them the clinical benefit of, it's not going to be 18 months in everybody, but even if it's 6 months, you might be shortchanging the patient the clinical benefit of that period of time by taking them off too quickly. And as we pointed out earlier, enzalutamide is a lot better tolerated than chemotherapy, which is often the next step. So as difficult as it may be to kind of watch a PSA go up every month when I see these patients, it is something I recommend, and I think that for some patients, it's a very, very good thing. And then, I think outside of a clinical trial, you may want to monitor them with scans every 3 or 4 months if they have a rising PSA to make sure you're not missing radiographic progression.
Another question is, this is not my field, and it's really challenging. There is I heard there is overdiagnosis of both breast cancer as well as prostate cancer. And because in old days, many people die of other diseases. Cancer only diagnosed when they had after they die.
I think you're right. That's why I've cleverly steered this talk to castration-resistant prostate cancer, because those men are likely to die of their disease. The debate in the field is really how to screen for prostate cancer, and does everybody who is diagnosed need to be treated? That's like a whole lecture in and of itself. I think that there's a lot of genetics and molecular markers that are being evaluated now to get us better at that. What we predominantly use for our treatment recommendations is something called the Gleason score. So it's basically a way to look at the biological aggressiveness of the cancer under the microscope. And so basically, based on that pathologic assessment, if they have low-grade disease, which is 6 or less, we often don't recommend therapy. We recommend something called surveillance. Anything that's intermediate or high grade, though, they're at greater risk of dying from their disease. 5 or 10 years ago, everybody diagnosed, or a large proportion of people diagnosed, even with low-grade disease, Gleason 6 or less, were treated. That shift has actually changed, and now a lot more are not. So we're learning and getting better at that, but we need more help. And you're right, that's still an obstacle.
Okay, thank you, Ravi.
Great. Thank you very much. I think we are done with questions because we got to move on to the next talk. But I'll just step out if anybody.
Okay, we have one announcement, and that being next Monday is a government holiday, Columbus Day. So we don't have class on Monday, we have class on Tuesday. And our next speaker is Sonia Jakowlew. So Sonia got her Ph.D. from Rutgers University. Subsequently, she did a postdoc in France. And she came to NCI in the 80s and started working on transforming growth factor beta with Michael Sporn, and she's continued to do that. The title, Transforming Growth Factor Beta and Lung Carcinogenesis. Sonia.
Good afternoon. Thank you, Dr. Moody. Now we're going to be shifting gears from prostate cancer to lung cancer. And just to take a short survey, how many people might be working on lung cancer in the audience? Anybody? We need more interest in this field. Okay. So today I'll be talking to you about lung tumorigenesis, lung cancer, and transforming growth factor beta. So today, as it was 2 years ago, lung cancer is the most common cause of cancer deaths among. Oh, this one? All right. That better? Okay. All right. So lung cancer today, like it was 2 years ago or 20 years ago, is the most common cause of cancer deaths among both men and women in the U.S. 2 years ago, there were over 221,000 newly diagnosed cases of lung cancer and over 158,000 deaths due to this disease. Now, because of the strong regimen of anti-cancer and anti-smoking campaign in this country, most cases of lung cancer now occur in ex-smokers. However, because of other regimens like secondary smoke, as well as persons who have to work in the coal industry and exposure to radon. Lung cancer is a serious disease in this country and continues to be. And unfortunately, the 5-year survival rate is still a dismal less than 15%. Now, my history is in TGF-beta, transforming growth factor beta, or TGF-beta for short. As a bit of background, TGF-beta is a multifunctional regulation of cellular growth and proliferation. It's a potent inhibitor of the proliferation of most normal epithelial cells in culture and shows widespread tissue expression. It plays a pivotal role in maintaining epithelial homeostasis and has been associated with various types of cancers, including lung cancer. And TGF-beta shows what is called a context-dependent inhibition or stimulation of cell proliferation and neoplastic transformation. That's a mouthful. But we think that TGF-beta is a very attractive candidate for new therapeutic intervention approaches, among these for lung cancer treatment. So to understand the TGF-beta, you have to go back to the beginning. And the beginning starts in the 70s with another protein called sarcoma growth factor. Sarcoma growth factor is a polypeptide that is secreted by Maloney marine sarcoma virus transformed mast fibroblasts that can stimulate the proliferation of normal rat fibroblasts to form colonies in soft agar. And this was a pivotal transformation assay that Joe DeLarco and George Darrow used and reported in the late 70s. Now, after the discovery of sarcoma growth factor, there are essentially two classes of TGFs that were isolated from MSV transformed cells. One class was shown to be able to compete with epidermal growth factor, EGF for receptor binding, and this class was termed to be TGF-alpha. Another class was shown not to be able to compete for EGF binding, but the colony-forming activity could be enhanced by TGF-beta, by EGF, and this was called TGF-beta. So sarcoma growth factor is really composed of at least two different polypeptides, TGF-alpha and TGF-beta, and unfortunately they share a term, but they're very, very different proteins. And this was reported by Robertson Sporn in the early 80s at the NCI. Following the discovery of TGF-beta, then steps were taken to purify this protein. And 3 different sources of purification were used, from human platelets, human placenta, and as well as bovine kidney, by 3 different researchers at the NCI, Drs. Brickasoyan, Chuck Froelich, and Anita Roberts. And purification, typically from bovine kidneys, typically started with using 100 grams of bovine kidney obtained from the local slaughterhouse. The kidneys were extracted with acid ethanol and then centrifuged and precipitated overnight in the cold room with about 50 liters of a solution of ether ethanol. The next day, the precipitate was dissolved in 2 liters of acetic acid and then applied to a 80-liter biogel P60 column and fractionated. So 1 liter fractions were collected, then lyophilized and redissolved for further chromatography. And using this procedure, a typical yield from 1 preparation yielded about 5 to 6 microgram of purified TGF-beta. And we call it TGF-beta 1 now because we know there are multiple isoforms, but at that time it was just known as TGF-beta. So to give you some idea of the size of the columns needed for this purification, this list shows the biogel P60 columns that were used, and the pink arrow on the right shows a 55-gallon drum that was used in the collection series. So the assay for TGF-beta involved the growth of normal right kidney cells, NRK cells, and soft agar. So for this assay, an agar base was plated on a petri dish, and then to that was added a mixture of media, serum, NRK cells, EGF, and a portion of the sample. This was then allowed to incubate at 37 degrees with CO2 for 1 week, and then the plates were stained and the colonies were counted with a instrument called an Omnicon image analysis system. And the typical analysis Omnicon system is shown at the bottom of the slide. Now, the concept is if TGF-beta is present in the sample, then colonies would grow and be counted. If no TGF-beta is present in the sample, no colonies would be grown and no colonies would be counted. So going through the purification, after the final HPLC purification, this slide shows a polyacrylamide gel of the samples that were run on it, and TGF-beta migrates as a 25,000 molecular weight entity shown by the arrow on the right in samples, in this case, between 56 and 60. So so TGF-beta was really born at the NCI, and Doctors Michael Sworn and Nita Roberts are credited as being the proud parents of this molecule. So following the purification of TGF-beta, the amino acid sequence of TGF-beta, now TGF-beta1, was determined. And TGF-beta1 was shown to initially exist as a pre-pro TGF-beta entity consisting of 391 amino acids, having a signal peptide at the amino terminus, a middle section which was termed the latency associated peptide or LAP, and a mature TGF-beta protein consisting of 112 amino acids at the C terminus. Now shown at the top is a cartoon of the amino acid sequence of TGF-beta, human TGF-beta1, and I'd like to draw your attention to the 9 cysteine residues in the cartoon, because these are very reminiscent and characteristic of the TGF-beta and TGF-beta family. Now, following the purification and sequencing, amino acid sequencing of TGF-beta, the crystal structure of TGF-beta was performed in the early 90s. And this happens to be the crystal structure of TGF-beta2, because evidently it was much easier to crystallize TGF-beta2 than TGF-beta1. So the crystallography shows that TGF-beta is a dimer consisting of 2 identical monomeric chains held together by an interchain disulfide bond, which forms a hydrophobic pocket. And in the pocket are these 9 characteristic cysteine residues that form a structure that has been termed the cysteine knot. Now, TGF-beta is really the matriarch of what is called the TGF-beta superfamily. The superfamily consists of the 5 TGF-beta isoforms, TGF-beta1, 2, and 3, that are found in mammals, TGF-beta4 found in the chicken, and TGF-beta5 in amphibians. In addition, the superfamily also contains the bone morphogenetic proteins, also known as growth and differentiation factors, as well as the activins and inhibins. Now, so to summarize what I've been speaking to you about, TGF-beta is a 25,000 molecular weight disulfide bonded homodimer. 3 highly homologous isoforms exist in the mammals, and these are TGF-beta 1, 2, and 3. Principal sources of TGF-beta in humans include the platelets, bone, and spleen. Most cells express TGF-beta as well as its receptors, and TGF-beta is usually secreted in what is called a latent inactive form that must be activated in order for the molecule to perform its many wondrous events. And the superfamily of TGF-beta includes not only the TGF-betas per se, but the activins, inhibins, BMPs, and GDFs. So the TGF-beta superfamily is really a large superfamily and is a central control module for many biological processes that are important to health and disease, including development, immune system function, reproduction, angiogenesis, aging, tissue repair in response to injury, metabolic regulation, and proliferative homeostasis. So with TGF-beta being involved in so many important control mechanisms in the body, it's a dream for somebody trying to get grant money from the NIH, and that's what they did, okay? So the major biological responses regulated by TGF-beta include the laundry list of it is able to inhibit proliferation as well as to regulate such important processes as apoptosis, differentiation, and immune cell function, as well as being able to stimulate the accumulation of extracellular matrix and promotion of chemotaxis in certain cell types. Now, throughout the years, a model for the TGF-beta signaling pathway has been developed, and some of this is controversial and still in the making, but this is the present model. So we start at the top left with the TGF-beta ligand, and that's shown in the blue triangles at the upper left. And the ligands may be TGF-beta as well as activins, inhibins, BMPs, GDFs, and so forth. So what happens is the ligand binds to the type 2 TGF-beta receptor, which is constitutively autophosphorylated. This then complex then recruits the type 1 receptor, shown in pink, and they form a complex, and the type 2 receptor transphosphorylates the type 1 receptor, okay? This then enables the complex to then bind to proteins called SMAD proteins, and depending on whether the ligand is an activin, TGF-beta, or BMPs, the SMAD proteins may be the SMAD proteins or the SMAD2 or 3, in the case of TGF-beta and activin, or SMAD1, 5, or 8, depending on which BMP is involved. Once this complex is formed, the receptors are able to transphosphorylate SMAD proteins, and then these enable the next step in the sequence is to interact with the common SMAD protein called SMAD4, shown at the bottom of the slide. And this then enables the signal to translocate to the nucleus, where it's able to control different types of transcriptional events. Now, the whole process can be circumvented by inhibitory SMADs called SMAD6 or SMAD7, again, depending on which ligand is involved. So, in addition to the bench research, TGF-beta has been examined in the clinic, and in the clinic, TGF-beta has been shown to have tumor suppressor properties. Firstly, germline mutations in various TGF-beta pathway components have been shown to cause familial predisposition to cancer, For example, SMAD4 has been shown to be mutated in juvenile polyposis syndrome. Secondly, the TGF-beta pathway components have been shown to be either somatically mutated or deleted in some human cancers. For example, the type 2 receptor in HNPC, CC, as well as the SMAD4 deletion in pancreatic cancers, some pancreatic cancers. And thirdly, reduced expression of the TGF-beta signaling pathway component or overexpression of endogenous pathway inhibitors as well have been associated with disease progression. And this has been characteristic by some diseases in which the type 1 and TGF-beta receptor have been overexpressed, or the SMAD7 and the SMAD7 regulated ski protein have been shown to be overexpressed as well. Now, in addition to the tumor suppressor properties, TGF-beta has also been shown to be able to act as a tumor promoter. So in this case, TGF-beta 1 has been shown to be elevated in many advanced types of human tumors and to be correlated with metastasis or poor prognosis. And the lung is part of this list of tumor types. And shown in the lower right-hand corner is a histological staining of a prostatic adenocarcinoma stain for TGF-beta 1. And you see the brown staining. TGF-beta is at the interface between the tumor parenchyma and the microenvironment. So, what is TGF-beta doing in carcinogenesis? Is it a hero as a tumor suppressor or a villain as a tumor promoter? Well, it turns out that it's a very complex story, and it turns out that TGF-beta can be both. TGF-beta can be a proximal effect as a malignant tumor phenotype. It can also act as a potent growth inhibitor and tumor suppressor. And it could be a pro-metastatic factor. Much of this is relegated to the context and the environment. So a unifying hypothesis has been developed over the many years, and it seems that general thought is that TGF-beta can switch from being a tumor suppressor to a pro-oncogenic factor during cancer progression. And how does it do this? Well, in the normal epithelium, the tumor suppressor properties predominate over the pro-oncogenic activities of this molecule. But as changes occur in the genetic and epigenetic context, as tumorigenesis proceeds, TGF-beta responsiveness goes down and is lost. And at the same time, expression and activation of TGF-beta is increased. So, as tumorigenesis proceeds to metastasis, the pro-oncogenic activities tend to start to dominate over the tumor suppressor activities and increase with tumorigenesis and metastasis. So now I'm going to shift to, the story becomes a little more complex. And I've just told you about the SMAD-dependent pathways for TGF-beta. Well, it turns out that there are a number of different SMAD-independent pathways by which TGF-beta can also operate. This includes the TAC-junk pathway, the RAS-MAP kinase pathway, the ROA pathway, and the protein phosphatase 2A pathway that functions in different types of cells. So we became more interested in the RAS-MAP kinase pathway in our studies of lung tumorigenesis because The KRAS proto-oncogene has been shown to be activationally mutated in at least 25 to 50% of human lung adenocarcinomas. It's been further shown that mutation in one allele of KRAS increases the appearance of human lung lesions. In addition, there's been shown to be avid crosstalk between SMAD-dependent pathway and the RAS signaling pathway, and activation of the RAS pathway can modulate the TGF-beta signaling pathway through the SMAD proteins. And finally, in vitro studies have shown that TGF-beta dominates over the mitogenic effects of RAS, but that activated RAS can override the interproliferative effect of TGF-beta. So there seems to be a possible interplay between TGF-beta and KRAS. Yes? Stay tuned. Okay, stay tuned. And I hope I can answer your question. Okay, so how does TGF-beta be involved in tumor suppression and then in tumor promotion? Well, in our model here, we can put forth at least 4 different pathways. In order to activate the tumor promotion pathway, one can have decreased levels and activities of the type 2 receptor, or one can have a hyperactivated MAP kinase pathway through activation of the RAS oncogene, proto-oncogene. Thirdly, you could have decreased levels or activities of the SMAD proteins. And the fourth possibility is a compromised effector function in the suppressor arm of the TGF-beta pathway. All of these are possibilities. So we kind of tried to test them out. So the broad goal of our lab was to determine the role of TGF-beta in the development and malignant transformation of lung epithelial cells. And this work was done in the epithelial carcinogenesis section of the Cell and Cancer Biology branch of NCI. We had 3 objectives. First, examine the effect of TGF-beta deletion and KRAS mutation alone and in combination on lung tumor incidence and pathology. Then to determine the early events that occur in the development of lung lesions and their progression with tumorigenesis, and then to identify any potential signal transduction pathway changes that occur with increasing tumorigenesis. So to do this, we employed 4 mouse models: the AJ mouse model, the C57 TGF-beta1 heterozygous mouse, the AJ Black 6 TGF-beta1 heterozygous mouse, and the TGF-beta1 heterozygous KRAS latent activatable mouse. And I'll briefly describe these 4 experiments. We had 2 questions. The first, does lung tumorigenesis affect the TGF-beta signaling pathway? And the reciprocal question, does the TGF-beta signaling pathway affect lung tumorigenesis? So we first started our study with using the AJ mouse model. This mouse model is very susceptible to chemically induced lung tumors, and the tumors that develop in a very time-dependent manner with the appearance of hyperplasia, adenoma, and carcinomas. And the carcinomas that develop are histologically similar to human lung adenocarcinomas. In addition, the same molecular mutations occur in both human and mouse lung tumors, such as overexpression of KRAS and loss of p53. So we began our studies using ethyl carbamate as the carcinogen. Ethyl carbamate can be metabolized in 2 pathways. There's a detoxification pathway shown on the left that involves an esterase, and just proceeds to harmless ethanol, CO2, and ammonia. There's another pathway, a bioactivation pathway that occurs through CYP2E1 in the lung, and this results in vinyl carbamate and a vinyl carbamate epoxide that are agents that are able to bind to macromolecules like DNA and start doing bad events. So to produce the tumors in the aging mice, we injected mice with 2-month-old mice with ethyl carbamate and sacrificed groups of 20 mice over monthly intervals over 12 months. Shown here is an histological immunostaining pattern of TGF-beta1, the type 1 TGF-beta receptor, and the type 2 TGF-beta receptor in mouse lung tumors at various age. Now, we see intense brown staining for TGF-beta1 and the type 1 receptor in tumors from 2 months, 4 months, and 8 months sacrificed mice. But if you look at the panel on the right for the type 2 receptor, you will see that there's significantly decreased staining for the type 2 receptor in 2-month lung tumors, and virtually non-existent staining for the type 2 receptor in 4-month and 8-month tumors, mouse lung tumors. This is shown more strikingly on the left, where we compare staining for the type 1 receptor and the type 2 receptor. Well, we see very brown staining for TGF-beta type 1 receptor in both the tumor shown in pink in panels A and B, as well as in the accompanying normal lung bronchioles shown in red. When we look at staining for the type 2 receptor, well, we see significant staining in the normal lung bronchioles in panel C and D, shown by the red arrows. We see virtually decreased staining for this receptor in the tumors. We also looked at the mRNAs for type 1 and type 2 receptors, and we saw levels of the type 1 receptor in all 5 mouse lung cell lines. When you look at the type 2 receptor in the lower right panel, you will see that there's decreased expression of the type 2 receptor in LM11 and the PCC4 cell lines. The PCC4 lines are strikingly because this is known to be derived from an ethyl carbamate-induced lung tumors. So we also looked at the expression of these proteins in benzpyrene-induced aging mouse lung tumors, and using immunohistochemical staining, we see very much the same expression staining that we saw with ethyl carbamate, namely intense staining for TGF-beta1 and the type 1 receptor in decreased expression of the type 2 receptor. Shown at the bottom of the slide is immunohistochemical staining for TGF-beta1 in normal lung bronchioles, as well as the type 1 and type 2 receptors. So we see decreased expression of the protein for the type 2 receptor in the tumors. Now, we also performed in situ hybridization for looking at the mRNAs for these proteins in the middle of the slide, and see expression of the mRNAs for TGF-beta1 as well as the type 1 receptor. When we look for the staining for the type 2 receptor, it's much decreased, going along with the decreased level of the protein in these tumors. So Our model shows that with using the aging mice that there is decreased levels and activities of the type 2 receptor in our mouse model system, which goes along with promotion of lung tumors. Our next question was to determine whether deletion of TGF-beta1 affects lung tumor genesis. And for this, we employed the C57 Black 6 TGF-beta1 mouse. Now, the C57 Black 6 TGF-beta1 knockout mouse was generated in the 80s. It's born and thrives, but about 3 weeks after birth, it succumbs to a genital wasting syndrome. So this kind of mouse is not very good for long-term carcinogenesis studies. So, but when we look at the TGF-beta1 heterozygote litter mate, it's born, it thrives, and it can proliferate into adulthood. So Dr. Lala G. Wakefield at the NCI uses mouse to look at liver cancer. So she treated these mice with nitrosamine and looked at the percentage of mice with tumors and found on the lower left slide that there's an increase in the percentage of mice with tumors in the heterozygous strain compared to the wild-type litter mice. Now, surprisingly, she also looked at the lung and surprisingly found that there was also an increase in the percentage of mice with lung tumors compared to the wild-type litter mice. So we kind of became very interested in it at that point. And in order to be able to study this in the lung better, because C57 Black 6 mice are not conducive to studying lung cancer, we crossed the AJ mouse with C57 Black 6 TGF-beta1 heterozygous mouse to generate an F1 generation of TGF-beta1 heterozygous mice and wild-type litter mice. So our strategy was to dose these mice, 2 groups of mice with carcinogens to generate lung tumors. So before we dosed them, we wanted to determine that we really had the mice, the bona fide mice that we wanted. So this shows an immunohistochemical staining pattern of TGF-beta1 in the lung bronchioles of these mice. Now, the wild-type mice on the top upper left shows abundant staining for TGF-beta1 in the bronchioles. These are normal. These are so-called normal mice before they get carcinogen. Now, in the middle panel shows the heterozygous mice, and you see really depressed expression staining of the TGF-beta1 here. We also did in situ hybridization with antisense probes and show similar reduction in expression of the TGF-beta1 in the heterozygous mice compared to the wild-type mice. Now, we also verified this with northern blotting shown at the bottom left, as well as competitive RT-PCR, and that's kind of dates this research, okay? So we see reduced expression of TGF-beta1 in the heterozygous mouse compared to the wild-type litter mate, and these are so-called normal mice. So we used the same strategy we did with the AJ mice. We injected our ethyl carbamate into TGF-beta1 heterozygous and wild-type mice at 2 months old, 2 months of age, and then sacrificed 20 mice per sacrifice over a period of 12 months. And then we looked at the carcinogen-induced lung tumor genesis in these mice. And shown in panel A at the type are hyperplasias, panel B adenomas, and panel C carcinomas. And the TGF-beta1 heterozygous mice are shown in the red compared to the green wild-type mice. And I think in the hyperplasia and adenoma, it's very evident that there's increased tumor incidence as well as multiplicity numbers and then decreased tumor latency in the TGF-beta1 heterozygous mouse shown in red compared to the wild-type littermate shown in green. And I would like your attention drawn to the panel C, the carcinoma, because while we see carcinomas appearing in the heterozygous mice by about 4 months, it takes about 1 year to see these carcinomas appearing in the wild-type littermates. We looked at the staining for an expression of the type 2 receptor proteins in these lung lesions and saw decreased expression of the type 2 receptor and carcinomas. These are shown in the bottom right panels in the heterozygous mice compared to the wild-type mice. Now, we also looked at the relative levels of the type 2 receptor mRNA levels from these mice as they were treated with ethyl carbamate with progressing tumorigenesis. And we were able to see decreasing levels of the type 2 receptor mRNA as lung tumorigenesis increased proceeded from hyperplasia to adenoma and then on to carcinomas. So our third question was, does deletion of TGF-beta1 and mutation of KRAS affect lung tumorigenesis? Because TGF-beta and KRAS are theoretically forming a story. For this question, we use the TGF-beta1 heterozygous KRAS latent activatable mouse. Now, to study the interplay of TGF-beta1 and KRAS, we had to generate these mice. We crossed the TGF-beta1 heterozygous mouse, which was NC57 black 6 strain, with the KRAS, with a mouse called the KRAS latent activatable mouse, which was in a strain SV129. And we could obtain these mice from Tyler Jackson. I don't have time to go into what is a KRAS latent activatable mouse. It just, for sake of argument, it's just activatable with a second hit. So we were able to generate 4 different genotypes from these mice. The TGF-beta1 heterozygous KRAS latent activatable mouse, which I'll call the double mutant. The TGF-beta1 wild-type KRAS latent activatable mouse, which I'll call just the KRAS single mutant. The TGF-beta1 heterozygous KRAS wild-type single mutant, and the wild-type littermate. So shown here are mouse lungs after dosing with carcinogen, and these were extracted from mice that I believe were 3 months of age. And one can see in panels A and B these pearly white nodules that indicate these lung tumors in the double mutant shown in panel A and the KRAS single mutant shown in panel B. We don't see tumors forming in the TGF-beta1 heterozygous mouse or the wild-type littermate, except on the rarest of occasions. So we looked at the effect of TGF-beta1 gene deletion and KRAS mutation on mouse survival. And to make a long story short, if you concentrate on plots for A and B, A is the double mutant and B is the KRAS single mutant. And we see decreased lifespans of both these mice compared to the TGF-beta1 heterozygous single mutant and the wild-type littermate. Now, we looked at the pathology of lung lesions in these mice and show that there's increased hyperplasia and adenomas in the KRAS single mutant, but increased numbers of carcinomas in the double mutant shown in the bottom panel. We looked at the expression of TGF-beta1 and the type 2 receptor proteins in these mice and showed that there's increased levels of TGF-beta1 and type 2 receptor in the double mutant adenocarcinomas shown in the panels with the pink arrows compared to the wild type in the single mutant. Since we're interested in the signaling pathway, we also looked at the type 2 receptor as well as the SMAD proteins. And I won't go through all of this, but suffice it to say that in the double mutant, we see on the right upper panel, we see expedited reduction of the type 2 receptor protein and increased production of the SMAD3 protein in these mice. We further extended our evaluation of the TGF-beta pathway. In addition, we see reduced production of SMAD4 and SMAD7 proteins, as well as expedited production of KRAS and RAF1 in the KRAS signaling pathway. We also looked at the apoptotic index in the single mutant and double mutant mouse lung adenomas and were able to show reduced apoptosis in the double mutant adenomas shown in red, okay, compared to the KRAS single mutant. So our model system shows that essentially one can have the tumor suppressor function of TGF-beta migrating to be the tumor promotion activity of TGF-beta by at least 4 different pathways in these mice that can develop into promotion of lung tumors. So in addition, I thought I'd add this slide at the end. There's quite a bit of activity quite recently about using anti-TGF-beta compounds in clinical trials. And there are various companies that are now looking at using various antibodies, antibody targeting alkynes, antisense oligonucleotides, as well as receptor kinase inhibitors, and combined use of TGF-beta in vaccines against particular types of cancer. And I want to draw your attention to a compound called Leukinix, which is being developed by NovaRx against the targeted TGF-beta 2, and that's currently in phase 2 trials against non-small cell lung cancer. So I'd like to acknowledge the people who really did this work. Jerry Anderson, he's now GW, as well as Yang Kang, Elena Nomova, Joseph Pandy, and Sarah Frist. And MIT, we thank Tyler Dex and Kim Mercer for the KRAS latent activatable mouse. And I'd like to answer any questions you might have in the next 5 minutes because I have to run and catch a bus or I walk back to Shady Grove. Okay.